And welcome to today's edition of Batcast. Hope you all are staying safe amidst this uh, unprecedented and challenging times. Today is May 8, 2020. I am Rifat Manan from Philadelphia, and I am remotely joined by my good friend Emilio Madrigal. He is in Boston. Today, we are excited to welcome Dr. Daniela Allende. She is the Director of Hepatobiliary and Pancreatic Pathology at the Cleveland Clinic. For the next 1 hour, she will be discussing on pattern approach to non-IBD colitis, a case-based discussion. And as always, please feel free to post your questions and comments on both Facebook as well as YouTube chat windows, and Dr. Allende will be answering them towards the end of the session. Thank you, Dr. Allende, for joining us today. Over to you.
Thank you. Thank you for inviting me. I'm very excited to do this lecture this morning. I hope you guys are awake. I had enough coffee, I think. So I plan a very dynamic session for you guys. It's a case-based discussion. We're going to go over some scan slides as well as a PowerPoint presentation to highlight some of the most important features that I want you to walk away with. At the end of this session, we're going to have a few questions. So I warn you right now, so you pay attention to some of the concepts and hopefully we can answer the questions together. So I want to start with the outline for this talk. We're going to talk about general features of approaching a biopsy that has colitis. Although we're going to focus on non-IBD colitis, the approach is also applicable to IBD cases because many times we don't know that the patient has IBD. So we're going to talk about that. Then we're going to use the cases to describe specific patterns of injury. We're going to focus on what are the key histologic features that define each pattern. What is the differential diagnosis that goes along with that pattern? And I want to share with you some diagnostic pearls, things that I learned over the years and things that are also written in some books that we should be looking for specifically when we see a pattern of injury to hopefully diagnose the underlying etiology for that pattern. So as you know, there are common patterns of injury that present in the colon. We take this approach basically because the colon will respond in a certain number of ways to injuries. So multiple things can show up in the colon in a colonic biopsy similarly. Those patterns, and I would say these are the most common things that we see, are acute and or chronic colitis, lymphocytic and collagenous colitis, eosinophilic colitis, ischemic colitis, and apoptotic colopathy. Some people will prefer to use the term paucicellular colitis for the last one. This is a different approach. This is a paper that my good friend Deepa Patil published a few years ago. You can see how the take on this one is a little bit different, but using the same concepts. And here the focus on differentiating or coming up with a differential diagnosis is based on the inflammatory infiltrate that is present in the lamina propria. So predominantly lymphoplasmocytic, neutrophilic, eosinophilic, or paucicellular. I include this for completeness. Sometimes this approach becomes handy for certain cases. The slide is here to remind me to talk about normal histology. I think this is very, very important. I always teach our residents, first we need to learn normal, to know what is abnormal, right? And normal can be very challenging because there's a wide range of normality. So in a very brief way, I will say that the colonic mucosa will have an even distribution of crypts. So they are equally spaced pretty much. They have different shapes, but pretty much rounded on cross-section. The epithelium on the surface is intact in this case with abundant cytoplasm and goblet cells that are obvious. They're also present in the crypts. The lamina propria is variably cellular. Let's remember that the cellularity on the right side of the colon is more prominent. The lamina propria becomes less cellular as we move towards the distal aspect of the colon. All the crypts are pretty much touching the muscularis mucosae in this case, which is normal, right? So let's go to case number 1. And let me pull the scan slide. So this was a 45-year-old patient that came to the clinic with a history of 2 weeks of diarrhea after traveling. It wasn't going away. They decided to do an endoscopy. There was some mild erythema, but nothing very significant. So they took random biopsies. And you can see how there are multiple fragments of colonic mucosa. Overall, I will say there is a normal architecture. There's muscularis mucosae with an even distribution of colonic crypts touching the muscularis mucosae, as we just saw. I want to highlight this area. This causes confusion sometimes. There's a slight, I would say, architectural abnormality here, but it's right above a lymphoid aggregate. So we're not gonna pay too much attention to that. That is frequently seen. It doesn't mean that this patient has chronic features. It's just normal sometimes. So, but what is abnormal with this case is there are areas in which the lamina propria becomes a little more cellular in comparison to some areas that are more edematous. When we get closer in those areas, we can see how there is crypt injury with attenuated epithelial cells, very eosinophilic cytoplasm and hyperchromatic nuclei. There's inflammatory cells in the lumen with, well, when I get a little closer so you can see it, some eosinophils, some neutrophils, and also cellular debris. Here there's another example. So it was patchy, but definitely evidence of micro abscesses. So let's go back to our PowerPoint. So basically, this is a case of acute colitis. The defining features of this pattern of injury are cryptitis, which means neutrophilic infiltrates injury in the crypts with reactive mucin loss, the cellular lamina propria that is composed of mixed inflammatory infiltrates, many times like plasma cells, like in this case. You can see some eos as well as neutrophils, like we have here. Like in our case, these cases evolved to have many times more prominent neutrophilic mediated injury with neutrophilic abscesses filling the lumen of these crypts. There's many times epithelial injury on the surface as well, a very cellular lamina propria, and these cases evolved to have full thickness ulceration many times. So what is the differential diagnosis? Infections, ischemia, medications, inflammatory bowel disease are very common. It's not a comprehensive list, but it's the most frequent things that we see in clinical practice. I listed down here bowel preparation. It doesn't mean the bowel preparation gives you acute colitis, but many times we see rare intraepithelial neutrophils in cases of bowel preparation. So it may come up in the differential for that reason. But obviously the patient shouldn't have any clinical symptoms if it was bowel preparation. So let's look at some specific cases that I want to highlight because there's a chance that we can identify the underlying etiology of that acute colitis. So in this case, we can see that there's neutrophilic mediated injury in that crypt, but in the lumen, we see these microorganisms. This is cryptosporidium. These are very tiny, 4 to 6 microns, and they are visible on H&E. So I think if we're seeing a case of acute colitis, it's worth checking the luminal aspect of that biopsy. CMV is also another thing that we can identify on H&E. Many times the inclusions, they could be intranuclear or cytoplasmic inclusions. They can show up in the endothelial cells, stromal cells, and sometimes epithelial cells. I would say I find personally challenging to see these inclusions in cases of deep ulceration and a lot of granulation tissue, sometimes just because it's a VC case, VC biopsy. So you can always do the immunohistochemistry for CMV, which nicely highlights the inclusions for us. Can you guess this one? I'm gonna give you a second to think while I describe it. These cases can be challenging. This was an ulcer that was basically being coming back, the regenerative changes in the setting of an ulcer. We can see how some of the enterocytes here have nuclear changes, smudgy chromatin at places, some intranuclear inclusions. This was a case of adenovirus in a patient that was transplanted. So we see adenovirus more commonly in pediatric population, but sometimes we see it in the adult population also in the setting of immunosuppression. I want to make a comment here about the differential of chronic colitis. I think one of the important things that I want you to walk away with today is understanding what are the features of chronic colitis and how to differentiate this from acute. Chronic colitis is defined histologically, I would say primarily by the presence of architectural distortion. From time to time, we'll see cases diagnosed as chronic non-specific colitis. My impression is this, they are referring to the inflammatory infiltrating the lamina propria, but I discourage that terminology because I think it's less specific of this diagnosis of chronic colitis, and I think it gets clinicians confused. When I use the term chronic colitis, and I think this is widely accepted among pathologists, is the presence of architectural distortion, in this case, branching of the crypts. The crypts are not evenly distributed. There are areas in which there's crypt dropout. There are missing crypts, right? When we get to the deeper portion of the mucosa, we can see how there's shortening of the crypts, so the crypts do not touch the muscularis mucosae anymore, so there's a space, and that space is filled with lymphoplasmocytes, typically, so lymphocytes and plasma cells, and this is what is called basal lymphoplasmacytosis. We can see pyloric gland metaplasia, so this resembles the pyloric glands we see in the upper gastrointestinal tract, but they are not native of this location. This is a metaplastic change. And we also see left-sided Paneth cell metaplasia in these cases. So these cells with abundant eosinophilic granular bright red cytoplasm. Remember, if we have Paneth cells in the right side of the colon, even up to the transverse colon, that's normal. But when we find them in the left side of the colon, this is considered metaplastic. In some cases, we see features of both, features of chronicity, because we have architectural distortion, pyloric gland metaplasia, basal lymphoplasmacytosis, but also we see acute features of cryptitis. So these are the cases of chronic active colitis. Although we see this very commonly in the setting of IBD, there are many other things in the non-IBD spectrum that can present this way. So it's more of a pattern of injury and not disease specific. So I have this slide to make it very straightforward. So when we're trying to decide, is it acute or chronic, what are the features that we need to look for? So for acute, obviously the defining feature is neutrophilic mediated injury, cryptitis, crypt abscesses, all the way to ulceration. But we shouldn't have any features of chronicity. On the other hand, chronic colitis will have all those features of chronicity, architectural distortion, basal lymphoplasmacytosis. Metaplastic changes can be there, but they are not always there. Same for neutrophilic infiltrates. Sometimes there is activity, sometimes there isn't. So let's focus on the architectural changes and basal lymphoplasmacytosis. Comparing the differential diagnosis, for these two patterns, I think it's very similar. At least the most frequent things that we see, infections, ischemia, medications, and IBD are in both. So it's very easy to remember when you are trying to list a differential, what are the things that we need to take in consideration. There are a few other things like radiation, diverticular disease, solitary rectal arsen syndrome, and many others that are probably more frequently seen in the setting of chronic active injury or chronic injury rather than acute. But overall, I think there's significant overlap. When we're talking about infections, there are infections that present more commonly in the acute setting, these things that do not go on forever. And those, because they have so much more pronounced of a clinical picture or symptoms that are more severe. So they bring the patients to clinical attention sooner, like CMV or enterohemorrhagic E. coli bacteria, for example, while other infections can be a little more silent or indolent at the beginning and have a more prolonged clinical course, like amoebiasis or mycobacteria, and cause of more of a chronic active colitis picture. So let me show you a couple of cases here. This is a 23-year-old female that presented with rectal bleeding and pain. She went to the GI doctor. They did an endoscopy and they found a rectal ulcer. The mucosa adjacent to that was erythematous. They were very concerned about IBD on this case, at least clinically. So this is what the biopsy shows. You can see how there's an area of ulceration with fibrinopurulent membranes. When we're looking at these two other fragments, this one has a little bit of architectural funniness, let's say, but considering that this is from the rectum, I will hesitate to call this chronic because we know that the rectal mucosa has a little bit of architectural distortion. The other thing that makes me hesitate to consider IBD is these other fragments. So if we get closer to some areas of the biopsy, we can see that there is some inflammatory infiltrating the lamina propria with reactive changes. But what is very obvious in this case is these bundles of smooth muscle encircling groups of glands. This is pretty typical of mucosal prolapse. So what this patient had was actually solitary rectal ulcer syndrome. There were no other areas of chronic active colitis anywhere else. In fact, it was more of a pink lamina propria in many of the fragments with this fibromuscular lamina propria, which defines the entity. I want to make a comment here because the name of this entity is a misnomer. These ulcers can be multiple. They can involve other segments, particularly the sigmoid colon, not only the rectum. And many times they are not even ulcers. They become erythematous mucosa or even slightly polypoid lesions. So just so you know of that. Chronic colonic ischemia is also in this differential of chronic injury. In this case, actually, I love this case because it shows how chronic colonic ischemia can mimic Crohn's disease. You can see how in this resection specimen there's deep ulceration of the mucosa with granulation tissue, thickening of the muscle, and transmural lymphoid aggregates with subserosal fibrosis. This is pointing out the lymphoid aggregates, so a perfect mimicker of Crohn's disease, but we knew that in this case, actually, the patient had ischemia. Something else in the differential of chronic colitis that I mentioned is diverticular disease-associated colitis. These cases in a vacuum, if you don't have a clinical history, you can actually mimic IBD very well. You can see how in a resection, you can appreciate the diverticulum going down beyond the muscle layer. When you get closer into the mucosal surface, you can see that there's something going on there, which is basically architectural distortion with some funny shaped glands, some branching, shortening of the crypt. So all the features of chronicity that we just discussed. In addition to that, there's probably some neutrophilic abscesses. Here is a higher magnification of those neutrophilic abscesses, even a crypt abscess. So perfect picture of chronic active colitis, but what we have to pay attention to in this particular disease is this is limited to the diverticulum. When you look at the mucosa adjacent to the diverticulum, it looks absolutely normal. And it's segmental because it only affects the segment of the diverticulum. TB, this is a biopsy of colonic mucosa towards the ileocecal valve. So you start to see a little bit of the villiform architecture as we move into the ileum, features of chronicity, and the classic granulomas that are necrotizing, very epithelial looking aggregates of histiocytes. And the stains usually, we order them. I would say most of the times are negative. If you find organisms, sometimes they are very few and hard to see. So we know that these stains have a low sensitivity for the diagnosis of mycobacteria. So if we have a big level or a high level of suspicion, we tend to reflex these cases to PCR. Lastly, amoebas. Amoebas actually can cause, like in this case, deep ulcers with granulation tissue. The clue to the diagnosis is typically in the lumen of those ulcers where we see the amoebas floating. They mimic histiocytes. They have this fluffy, abundant, pale cytoplasm. A clue to the diagnosis is if you pay attention to this case, you can see how human chromatin is very hyperchromatic, dark blue, while the amoebas tend to have a very light magenta chromatin. So that's a clue that these are not histiocytes. So let's look at case number 2. Let's go back to the panel of cases. We're gonna do case number 2 in this biopsy and number 3 together. Okay, so this was a 49-year-old male that presented with watery diarrhea. The endoscopies didn't see many changes in the colonoscopy. They did random colonic biopsies. So you can see how there are several fragments. The architecture looks fairly normal in this particular case. There's an even distribution again of the crypts. And as you are gonna see throughout my presentation, I like to see the low power view first. I like to look at the architecture and my low power impression first, and then I get closer to look at specific features that I wanna see. The other thing that I can pick up in this case is not only a normal architecture, but a blue lamina propria. That tells me there's something going on here, and I'm not gonna dismiss this case just yet. As we get closer in this case, we can appreciate there's some intraepithelial lymphocytosis, maybe a rare apoptotic body, but the lamina propria is quite blue. So let me keep going and show you other areas of this biopsy. We're gonna go to a different field. And there's a little delay, so I know that you are you may not see it right away. But anyways, here, more lymphocytosis at places. The surface epithelium was at places okay. Some areas had a few less goblet cells that we would like to see. Was slightly denuded at other places. Here is a little more attenuated as well in a few lymphocytes. This patient actually, by the time that we got this biopsy, had this diarrhea for a long time, has been tested for a lot of things, and everything came back negative. So the diagnostic suspicion at the time was lymphocytic colitis. This is from a 65-year-old female, also with chronic watery diarrhea, maybe more of a striking case. Again, normal architecture. When we go to the close up a little bit, we can still pick up the blue lamina propria. As opposed to the previous case, I think in this case there's a much more striking picture of intraepithelial lymphocytosis. So you can see all the lymphocytes attacking those crypts. They're also present in the surface epithelium. The surface epithelium goes from areas that is more intact to areas that lose a little bit of the goblet cells, so more reactive. In addition to that, this case, and let's see if we have a better view here, has denudation of the surface epithelium, which is a frequent finding in some of these cases that are more severe. If you look at the subepithelial region here, the other finding of this case is this thickening of the subepithelial collagen table. Normally, there's, I would say it's more like this. So the inflammatory cells present in the lamina propria reach pretty much the epithelium on the surface. Here, there's a gap that is filled up with subepithelial collagen. There's entrapment of capillaries and inflammatory cells in that area as well. I want to point out that there's a numerous or a very prominent eosinophilic infiltrate as well in the lamina propria in this case. So going back to our discussion, this was a case of collagenous colitis. We mentioned that it's basically the architecture in these cases is pretty intact, but one of the key features, because it's a colitis, is the blue lamina propria. There's intraepithelial lymphocytosis, like we see here, and as well as epithelial injury on the surface. What is the defining of this particular entity is the subepithelial collagen thickening with entrapment of capillaries and inflammatory cells. I want to mention that there's actually there's a defined thickness of the subepithelial collagen table. However, I would say in clinical practice, we don't measure how thick this is. It has to be obvious on the H&E. They do have prominent eosinophils in the lamina propria, so it seems that this is the cell type that is driving the fibrosis in collagenous colitis, and that's sometimes much more prominent than what we see in lymphocytic colitis. They may or may not have signs of chronicity. I would say it's not very common to see chronic injury in the setting of collagenous colitis, but there are cases that may present this way. This is a study that we published a few years back with Dr. Bronner. This is a series that she collected over the years in collagenous colitis patients. This article got a lot of traction on the clinical literature because this was a series of patients that actually had collagenous colitis, but they were presenting to the clinicians with chronic diarrhea. The endoscopy was normal, and they will come back hours later with a perforation. So at the time, it was hard to explain why the patients were having a perforation other than iatrogenic. So when we presented this series of cases with very well-defined features of collagenous colitis, now with these cracks, fissuring ulcers that were basically occurring after endoscopy, they felt a little more relieved that it wasn't their fault. Actually, the patient indeed had a predisposing condition for that. Lymphocytic colitis, on the other hand, has a lot of overlapping features with collagenous colitis. Normal architecture, again, for the most part, in blue lamina propria. These are called top-heavy many times because there's a little bit more enhancement of the infiltrate towards the surface. Some cases are very prominent, or I would say the infiltrate is very prominent in some cases with a lot of intraepithelial lymphocytes, sometimes apoptosis, but apoptosis is not very prominent in general in these cases. So again, a quick comparison between these two entities of microscopic colitis, and this is to show how much overlap there is between these two. So both presenting this in a similar fashion, chronic watery diarrhea with normal endoscopy for the most part. There's a female predilection that is more pronounced on collagenous colitis. That doesn't mean that these two entities cannot be diagnosed in male. And I would say that sometimes we get consults because of that, because it's not that common to see, but it can occur. There are some associations, celiac disease in both, basically, drugs, and lymphocytic colitis patients can have some sometimes positive autoantibodies like ANA. Collagenous colitis has up to 40% of the cases patients have an underlying autoimmune disease. That can be celiac disease or Hashimoto's thyroiditis or many others. There's also an association with smoking. Based on the histologic findings, there's a significant overlap between lymphocytic and collagenous in terms of the intact architecture, increased intraepithelial lymphocytosis, surface epithelial injury, and blue lamina propria. But what defines collagenous is that subepithelial collagen thickening, right? I want to touch base on these specific situations that many times cause confusion, and this is more from experience on what we do here with these cases. So if the patient has a history of lymphocytic colitis or collagenous colitis and now comes with a normal biopsy, sometimes people wonder, should I call this normal in remission? We call this normal. Actually, if we're not seeing features of collagenous colitis now, I call it what it is, what I see, right? Intact colonic mucosa or colonic mucosa with no diagnostic alterations, whatever the terminology you like to use. We have to make a comment here also that the disease is patchy, so sometimes it's a sampling issue that I want you to consider. Sometimes it's an effect of treatment. Patient now is in true remission. What happens with those cases that have rare intraepithelial lymphocytes, but we don't see much of a blue lamina propria, it's not good enough. For those cases, I typically say colonic mucosa with rare intraepithelial lymphocytes, see comment, and I provide a differential. The differential can range from bowel preparation sometimes, if particularly if the patient doesn't have any symptoms and this was an incidental finding, to viral infections, common variable immunodeficiency, celiac disease, many other things are in that differential, not just lymphocytic colitis. So that's the way we handle those. And lastly, those cases that are actually classic for lymphocytic or collagenous colitis, but now they show up with these features in addition to neutrophilic mediated injury. So neutrophilic mediated injury, we said cryptabscesses or cryptitis, are not very typical of this disease. However, I wouldn't argue having a few rare intraepithelial neutrophils. But if you see this as a more distinct feature, I tend to highlight this as this is not typical of this disease and may raise the possibility of a superimposed phenomenon such as medications or infections, in particular NSAIDs, I would say. Okay, so number 3. Let's go to case number 3 here. This is one of my favorite cases. You wanna see why. So this was a patient, I think she was 62. She presented with diarrhea. They didn't see much endoscopically, and they took random biopsies. The overall architecture looks okay, I would say. I don't see much of architectural distortion. I'm gonna focus in one area here because I think it's very obvious that there's something going on. The lamina propria is quite busy, but it looks red. So we want to get closer to see why is it red. There's a little bit of epithelial injury in this crypt. When we get closer, we can see that the lamina propria is filled with eosinophils, right? Bright, granular cytoplasm. Not only that, and I would say, we said eosinophils are a normal cell component of the lamina propria, but here they are the predominant cell type. There are sheets of cells. They are attacking some of these crypts. So that is, in my mind, abnormal. In addition to the eosinophils, there are some cells here. They look somewhat ovoid. They have more pale cytoplasm and oval nuclei. These cells not only show up around some of these crypts, but clustering somewhat underneath the surface epithelium as well. So I put this case in here because I want to talk a little bit about eosinophilic colitis. So let me go back to this case on the PowerPoint and highlight a few features for you. I think a very common question is, how many eosinophils do I need to call something eosinophilic colitis? And there are well-defined thresholds throughout the different segments of the gastrointestinal tract. I would say I don't count, because I think if we have to count for this, we're probably in the low end of the spectrum. Our diagnosis is going to be much less specific. The features that I like to consider for this pattern are this low power impression that there's too many eosinophils. They are forming sheets, clustering, like in our case. There's also the granulation of eosinophils many times, or eosinophils injuring the crypts, eosinophils that are reaching down, getting into the muscularis mucosae, like in this case, or even submucosa sometimes. Those are the features that make this diagnosis more specific and the ones that I use for clinical practice. A word should be said here that eosinophils are a normal component of the lamina propria, as I mentioned, so I'm not chasing rare eosinophils or eosinophils that mix with other cell types. I want to focus on those cases that eosinophils are the predominant cell type. There are variations that occur just because of the what normal mucosa looks like. The right side of the colon will have many more eosinophils. As we move toward the rectum, the left side and rectum, we're going to see much less of an eosinophilic infiltrate. There's also geographic variations. People living near the tropics have more eosinophils. That's why defining an absolute threshold becomes a little challenging in clinical practice, and I apply these histologic criteria that I mentioned. What is the differential diagnosis for this pattern? parasitic infections, drugs, IBD, connective tissue disorders, vasculitis, malignancies, and primary eosinophilic disorders, among many others. Primary eosinophilic disorders, I have to say, that are very rare. They present in pediatric patients, infancy, typically associated with allergies, so not so many. So back to our case, I pointed out those other cells that were clustering. These cells actually were CD117 positive, co-expressing CD25, so this was a case of systemic mastocytosis. This is not very common. Actually, most of the times that we see this eosinophils is something else, but this was a really fun case. There's a defined criteria for this entity, which includes this clustering of cells, plus minor criteria. So in our case, we fulfill this definition. I just want to point out that as opposed to systemic mastocytosis in other sites, there's this paper on systemic mastocytosis in the GI tract, and in their experience, some patients, the patients actually, they had available follow-up. They follow a more clinical, indolent clinical course. So when I diagnose these cases, I actually include that reference, so clinicians are aware. For the diagnosis, I tend to use, this is the way that we diagnose them here, although there are many different ways that you can diagnose these cases. This is more for those cases that I don't see any clinical or histologic concern for this diagnosis, but clinicians may ask you to do a CD117, and it will highlight the scattered cells. So basically, this is what I say: scattered mast cells highlighted on CD117 without confluent aggregates or aberrant co-expression of CD25. So it's not systemic mastocytosis. So let's go over case number 4. So this one, let's go back here. So this was a resection specimen. The patient was, I think, 78, presented with acute abdomen. Acute abdomen. So you went straight to the OR, they resected that segment, and this is what we received. So patient had a history of cardiovascular disease, so it was very helpful to know all this information. But from the histologic perspective, we can see how the wall here is pretty thin. There's actually attenuation of the external layer of the muscularis propria. When we get a little closer, we can appreciate that there's marked congestion of capillaries, even extravasated red blood cells or hemorrhagic changes. The mucosa looks gone at places, right? It's pretty necrotic. This is what we call the ghost crypts, because they are pretty much disappearing as we move along. The lamina propria looks very hemorrhagic and pink, and areas that are more intact in between will show a hypocellular many times lamina propria. In this case, there's not much of hyalinization, but rather hemorrhagic changes. And reactive mucin loss. If you remember the picture that I showed you earlier today with goblet cells, which is normal, in this case, we have lost many of the goblet cells. The residual mucin that is in is very in rare cells, so we have lost a lot of the mucin. There's the sloughing of the epithelial lining into the lumen, and areas that become necrotic and ulcerated. So as we move along, we can see that there are areas of intact mucosa and some areas that are more affected. Hemorrhagic changes can involve the full thickness of the wall. So in this case, I'm also showing you the vessels that they were, other than congested, there wasn't a primary pathology in the vasculature in this case. And the submucosa is quite edematous as well. So this was a good example of acute ischemia. This happens due to multiple reasons, including low blood flow states, which are systemic diseases many times, or thrombi and emboli, mechanical reasons, drugs, vasculitis, and infections. If you're dealing with a younger patient, and the case I just presented you was an older man, in younger populations or younger patients, I would say the differential is a little bit different. If they don't have predisposing conditions, sometimes it's contraceptive use or cocaine, vasculitis, infections, but not the typical cardiovascular disease or background that we expect for an older adult. Also, I've seen cases in marathon runners for due to dehydration, so something else to consider. The histologic features that define this pattern are actually the withering creeps, which are also sometimes called in the literature atrophic. They are not quite atrophic because they can be regenerative, but they do look smaller. They look like they have attenuated epithelium and marked basophilic or amphophilic cytoplasm with hyperchromatic nuclei. There are regenerative changes in the adjacent mucosa, and the lamina propria that is hyalinized becomes more obvious as the disease goes on for a little while. Otherwise, in the more acute cases, like in the case I presented, you may see more edematous or hemorrhagic changes. There's necrosis of the epithelium that starts from the luminal aspect and goes down into the mucosa with sometimes a spreading of the deeper creeps. And this is because of the distribution of oxygen. Let's remember that the oxygen goes from the deeper portion that is being fed by the capillaries that get into the colon all the way to the surface. So this is the area that has the lowest oxygen content, and this is why the necrosis occurs this way. The lamina propria, as opposed to the cases of colitis that we saw earlier today, is more pink, hyalinized sometimes, or hemorrhagic. As the disease, the patients recover sometimes, we may see some reparative changes that at times may pose the question of dysplasia in the differential diagnosis because there's marked nuclear hyperchromasia, enlargement, and sometimes even stratification and multiple mitotic figures as part of the reparative process. The differential also includes, in these cases, C. diff, because ischemia can present with pseudomembranes. There's almost mushroom-like fibropyrrolent membranes associated with necrosis. I included this reference. This is a paper that I published several years ago on ischemic colitis. It's a nice review if you want to learn more about this differential. But I pointed this thrombi here because this is something that we should be looking at. We should be looking at underlying causes leading to this ischemia. Sometimes it's vasculitis. This is another case that I had. This was a case of lymphocytic phlebitis. This disease is segmental, so the patients recover nicely after the segment is resected, and is basically affecting the veins with a lymphocytic infiltrate with some Schwann cells and histiocytes. The arteries are intact. Amyloidosis is sometimes could lead to ischemia. In this case, globular amorphous deposits, not only in the lamina propria, but also in the arterioles. And C. diff, obviously C. diff can be very challenging, particularly on biopsy samples and in the acute setting. Very similar picture to that picture that I just showed on ischemia. However, C. diff tends to have much more of a neutrophilic, prominent inflammatory infiltrate in the lamina propria. That would highlight maybe this more as a possibility other than ischemia, but again, there's significant overlap between these two. This paper actually from Dr. Greenson highlights the significant overlap between these two entities and things that not only on the endoscopy, but also histologically, and the things that they found useful, and I think I can concur with this, is the hyalinization of the lamina propria, the presence of withering creeps, and full thickness necrosis, as well as hemorrhagic changes in the lamina propria as more in favor of ischemia. When we're looking at the lumen, sometimes in cases of ischemia, we see this resins. This is actually a K-oxalate. This is used to treat hyperkalemia. It seems that it's not the K-oxalate causing the ischemia, but maybe those formulas that include sorbitol still out there for discussion. There are other resins that we can see sometimes in these cases, and this is a really nice paper that includes a morphologic approach to this. I think it's very helpful to have. So the first few actually have a very eosinophilic look, and they can be distinguished from each other many times, but no fish scales. While K-oxalate has a very purple hue and fish scales. Sevelamer is two-tone resin with a magenta stain on AFB. Radiation, only a few words on radiation. Acute radiation, we don't see it very often. It occurs more on the epithelial cells, while chronic radiation actually involves more the blood vessels and mesenchymal cells. And we see in the setting of previous radiation. This is a very old case that we had on radiation, acute radiation injury with regenerative crypts, as well as some epithelial changes in the endothelial cells. Chronic radiation is what we see more commonly. It has this chronic look of basically injury, but what is classic also in these cases to see this hyalinized foamy arteriopathy that characterizes these cases, as well as sometimes stromal atypia and endothelial atypia. We're gonna see the last case that I have for you today. So let's go here. This was a patient with a bone marrow transplant presenting with diarrhea. They didn't see much endoscopically, so they went ahead and did a random colonic biopsy. As you can see again, the architecture is fairly intact. The lamina propria is not particularly cellular in this case. So these cases can be challenging. I think these cases require more time, and we have to get a little closer to find the diagnostic features, because if you go quickly from the low power, we may consider this a pretty normal biopsy. Despite the shattering artifact that you can appreciate, I think everyone can see here that there's some apoptosis. This was throughout the biopsy, so these are apoptotic bodies. A clear halo is characteristic, and it helps us identify this even from the low power with fragmentation of nuclei particles here included in that halo. Other than that, there wasn't much of intraepithelial lymphocytosis, and as I mentioned, the lamina propria was pretty intact. Let me show you a couple of things in this differential. So that case actually that I just showed you was a graft versus host disease, and we're going to discuss these features a little more in a second. This is the classic differential diagnosis of this entity, and this was a case of mycophenolate toxicity. Mycophenolate, I think when we see these cases from the low power, is one of those things that instantly should come to your mind. This could be mycophenolate, and that is because the architecture looks a little funny, but it's not clearly chronic. The lamina propria can be variably inflamed, many times has a lot of EOS, but there's this isolated crypt injury, what we call isolated crypt injury, and sometimes increased apoptosis. When we see that, mycophenolate, among other things, should come to your mind. In a closer view, we can see the eosinophilic cryptitis there, maybe a little less apoptosis than the other case. The other thing that we typically have in this differential is, it can be, I think, in the differential is, this actually was a case of checkpoint inhibitor injury. So it looked okay. The patient actually had a history of melanoma. We knew the patient was on one of these drugs. There was diarrhea. The architecture was okay. But at places, you can see how this patient actually had somewhat increased apoptosis, as well as some intraepithelial lymphocytosis that was variable, and this area of more cellular lamina propria. So let me point out a few things that I want to share with you in this last differential. So these three entities actually fall into the category of apoptotic colopathy, pattern of injury. We discussed the first case was GVHD, the second one was mycophenolate, and the third case that I show you was a checkpoint inhibitor. Other things that are can present this way are infections, particularly CMV, CVID, common variable immunodeficiency. I will warn you, look for plasma cells. It doesn't mean that all patients with common variable immunodeficiency will not have plasma cells, but many times are reduced. If they are normal, we won't be able to pick out those cases, but sometimes they are absent, so it's worth checking for plasma cells in the lamina propria. Autoimmune enteropathy or enterocolopathy, those patients actually have increased apoptosis, but it's present typically in the deeper crypts, and they also will lose the goblet cells and Paneth cells as a defining thing of the defining feature of the entity. Bowel preparation, I put it here just because there are cases that the patient comes for whatever, the screening colonoscopy. There's no diarrhea, there's no clinical symptom. They don't see anything endoscopically, but we may see some increased apoptosis here and there. It is possible that that is an incidental finding with non-significant and is due to bowel preparation. So just keep that in mind. Graft versus host was our diagnosis on that case, and this is occurs in patients that undergo bone marrow transplant, stem cell transplantation. Classically, they will present with apoptosis. They can have creep injury. They can have eosinophils in the lamina propria, and some papers will highlight the pericapillary hemorrhage. I'm not sure I pick up on this feature a lot. But I want to comment a couple of things that are more practical on the apoptosis side. There's not really a minimum threshold defined for this diagnosis. The disease can be patchy, so sometimes we may have a sampling issue with this. That's why we do multiple levels for these cases. But it seems to be more practical and make the diagnosis a little more specific is to consider at least one apoptotic body per biopsy fragment, or at least the total number of apoptotic body found in the case equal to the number of biopsies that we have. And I want to highlight that we are looking for apoptosis in the deeper crypts. Apoptosis on the surface epithelium is not specific. Other features that other publications have highlighted are aggregated endocrine cells. These are endocrine cells, and hypereosinophilic degenerative crypts, like I show you in one of the cases. There's a grading scheme for GVHD. However, I tend not to use it unless the clinicians want me to report it. And the main reason for that is there's really poor correlation with endoscopic clinical impression and outcome. But if they ask you to do it, the way that you do it is all the grades have apoptosis. That's the initial step. And then as they lose isolated crypts or contiguous crypts, or all the way to ulceration is the way that goes from 1 to 4. What we do use is the terminology from 2015 NIH criteria that basically will categorize these cases into 3 groups. One is no GVHD. We don't have any features that are consistent with this diagnosis. Possible GVHD, we can identify features that can fall into this spectrum, but there may be other things that are also competing with that diagnosis, like CMV or patient being on mycophenolate. Lastly, there should be a 3, likely GVHD. There's unequivocal evidence of GVHD without any other competing diagnosis. This is a paper that looked at the spectrum of disease in mycophenolate. As you can see, mycophenolate can show up with multiple different patterns in a colonic mucosa biopsy, but it's commonly seen in the differential of GVHD because there's overlapping features there too. This is from the case that I just showed you, individual crypt injury with variable inflammation in the lamina propria and increased apoptosis. I like this paper because actually they pointed towards some features that we can use to favor mycophenolate over GVHD, and those include lamina propria eosinophilia, lack of endocrine cell aggregates, and lack of apoptotic microabscesses. So if you see things that are falling within this spectrum, maybe we can favor MMF. This is a pembro colitis. Actually, this looks more like a lymphocytic colitis to me with much increased apoptosis. And this is to highlight this new thing that we're starting to see more and more commonly. Patients are being placed on these anti-PD-1 drugs for multiple tumors. The case that I show you was a melanoma patient being treated with one of these drugs. They can present with lymphocytic colitis pattern of injury or with active colitis pattern of injury, frequently with associated apoptosis. As you can see, they come in a wide range of age presentation. Most of these patients do not have previous GI disease, and the disease can start very soon after initiation of treatment, but also very late. So I think it's worth considering this in the differential diagnosis. The disease can present with erythema and minimal changes all the way to ulcers. And this is just some examples of the different drugs that have been associated with lymphocytic colitis pattern of injury, but sometimes they present with acute colitis pattern of injury. So I think the key to this is to think of drugs, go back to the history, check on this in these particular drugs, in particular if you see increased apoptosis. So I walk you through a lot of entities today. Basically, what I want to point out, the way that we approach these cases is we try to identify the pattern of injury first. If we can do that successfully, that's half of the battle or more. We come up with a differential diagnosis within that pattern of injury. And that in combination with the clinical history and specific things that we can identify histologically, hopefully we can narrow it down to a single entity. So I warn you, we have a few questions here at the end. I hope to solidify some of the concepts with these questions. So the first one is, which one is not a defining feature of chronic mucosal injury? Pyloric gland metaplasia, basal lymphoplasmacytosis, cryptitis, or crypt architectural distortion? And I think you can use the chat to answer. I'm going to give you a couple seconds. Think about it. Hope it's not tricky. All right. Cryptitis, right? And cryptitis, I heard somebody. Maybe I went too fast. Cryptitis.
No, yeah. I mean, many of them are already saying cryptitis. Please go ahead.
Okay. Cryptitis is the one that I highlighted, and the reason for that is a defining feature of acute colitis, can be present in chronic mucosal injury, but it's not a required feature. Next question. Which histologic feature characterizes collagenous colitis? Intraepithelial lymphocytosis, withering crypts, eosinophilic mediated injury, subepithelial collagen thickening with entrapment of capillaries and inflammatory cells. So I'm going to give you some time. Rifat, if you want to give me a go when I go to the next one. I'm not
I'm not
able to see the chat, so.
Right. So I see the answer that D, that is subepithelial collagen thickening with entrapment of capillaries.
All right, so you got it right? So intraepithelial lymphocytosis can be present, but it's also seen in other things, including lymphocytic colitis. Withering crypt is a feature of ischemia, and eosinophilic mediated injury is a feature of eosinophilic colitis, although I pointed out that eosinophils are prominent in the lamina propria of these cases. We typically don't see eosinophilic mediated injury in general. So last question. Which entity frequently presents as apoptotic colopathy? Amyloidosis, oral contraceptives, GVHD, or Crohn's disease? The last one. So when you see some answers, just give me a go. No more.
Yeah, there is just, so you can see GVHD, many of them are opting for GVHD, that is option C.
Option C, okay, yes, that's what I want you to say. It was an example that I show. Amyloidosis, amyloidosis, it can be tricky, but I would say that I would put it more in the differential of ischemia, just because it affects the vasculature many times. Oral contraceptives, drugs are in differential of many things, but I placed that one actually in the ischemia category as well. And Crohn's disease, obviously, not something that we present with apoptosis many times, or typically with that pattern. So GVHD was the one. That's all for me today. This is my Twitter handle if you want to follow me, or if you have further questions about this lecture or anything else in the GI liver world, I'm happy to answer. And I'm happy to take any questions at this point.
Yeah, thank you, Dr. Allende. There are some questions. Sarika is asking, is there any special stain for cryptosporidiosis?
Any stains, she said?
Yeah, any special stain that you use for cryptosporidium?
Yeah, I pointed out in the lecture, I think in the slide, you can do stains that are partially stained with AFP, but the truth is we do diagnose this on the H&E. I think if there's any concern, you can always refer to clinical testing, so you can do a stool testing and others, sometimes depending on the organism, serologic testing. But cryptosporidium can be identified on H&E.
So another question that's from Dr. Patel. How do you report cases of chronic active colitis on biopsy where the differential diagnosis includes IBD and diverticular disease-associated colitis?
Yes, so that's a great question. When we have a biopsy, we will report the pattern of interest. So in that case, if the features are chronic active colitis, that's what we say. Here in our practice, we don't say consistent with IBD in the line diagnosis for a biopsy specimen. I only use that terminology for resections. So if we're dealing with biopsy, we're going to use the pattern of interest. We're going to say chronic active colitis, negative for granulomas and dysplasia, see comment. And in the comment, I integrate the histologic features that I see with the clinical picture. And I give the clinician a differential that will include IBD, diverticular disease, associated colitis, etc., etc. Now, talking about this specific differential of IBD versus diverticular disease associated colitis, I think as pathologists, because they are only biopsying sometimes the area near the diverticulum and may have these changes, we have very limited ways to tell them apart. Many times it's impossible. So the distinction between IBD and diverticular disease-associated colitis requires correlation with the clinical picture. So I think the best we can do is to describe the pattern and give them a differential. If they had biopsy, the area, they are not going to biopsy inside the diverticulum. They typically biopsy the opening of the diverticulum into the lumen, and that may show the features of chronic active colitis. If they biopsy that and they biopsy the rest of the colonic mucosa and is normal, I guess you can suggest, knowing that the patient has diverticular disease, that this may be a case of diverticular disease-associated colitis. But it is a diagnosis that requires clinical correlation. The other thing that I want to point out is I don't diagnose IBD on a biopsy for multiple reasons. First, I show you cases that look just like IBD and they are not IBD. And IBD is always a diagnosis of exclusion. The clinicians have to do workup, images, they have to have clinical information to make that diagnosis. And many times when the patient is first presenting, we don't have all that information at the time that we're reading the biopsy. So just to be clear, for biopsies, we diagnose the pattern of injury and we provide a differential. If there are specific situations in which we have clinical history and the testing has been done, we can probably go a little further. But a differential is still okay in that setting.
Thank you. There's another question from Irina. I hope I got your name right. So it's which antibody do you use for adenovirus?
Oh, great. I can probably follow up on that one because I can't remember the exact one that we use. But I have to tell you something very interesting about this antibody. We used to have a different antibody from one of the companies. And I had a case, actually the case that I show you, that is pretty classic. I was pretty convinced on the H&E that it was adenovirus. Then when we did the stain, it turned out to be, it comes back negative. And I'm like, there's no way, this has to be adenovirus. So I didn't give up on the case. I sent out the case to another lab, which they had a different antibody for adenovirus, and the immuno came back positive. We confirmed that diagnosis clinically. So one word of caution for adenovirus and antibodies is there are many different serotypes, and the antibodies commercially available, they have different combinations of serotypes. We obviously changed our own antibody after this case was discovered, because we realized the antibody that we were having was not capturing certain serotypes. So it was a good learning experience for us. So I'm happy to follow up with that person. Just contact me directly. I will find out which one is the antibody that we're currently using. I can't remember from the top of my head right now. But be aware that there's a different sensitivity based on the combination of serotypes that each antibody may have.
One question is from Khurshid. Khurshid wants to know, what are the distinctive features of autoimmune enteropathy?
Great question. I didn't touch on that one because it's something very rare. We don't see it very commonly, particularly here, as we don't see pediatric cases. It's in this differential diagnosis of apoptotic colopathy because these cases tend to have very prominent apoptosis, particularly in the deeper crypts. Sometimes you see some intraepithelial lymphocytes. But if you back off a little bit and you see these biopsies from the low power, they look very depleted of mucin as the antibodies are targeting goblet cells. The goblet cells disappear. The Paneth cells may disappear as well, as some other antibodies will target Paneth cells. So it looks it looks more like a mucosa that is busy in the lamina propria because it's inflamed, but there's a lot of reactive kind of changes and loss of Paneth cells and goblet cells. So it has a very particular look in addition to increased apoptosis.
There is a question from Suma Seshadri. So she wants to know, how do you differentiate denudation from ulceration? Sometimes beneath the denudation, we can see inflammation. So she wants to clarify from you.
If I got it right, it's denudation from ulceration. Is that
Right.
Yeah. So I'm not sure. I'm not sure if it's, you know, maybe a terminology thing. I use denudation of the surface epithelium when there's a sloughing off of the epithelial cells into the lumen. And I show you a case of collagenous colitis that didn't have any ulcer, and the epithelium cell gets denuded. And that's when I use the term denudation of the surface. Ulcer, I use ulcer more when I see granulation tissue. So the mucosa is fairly gone and replaced by granulation tissue. And that's my personal take on that, on how I use those two terms.
All right. Dr. Ambarish Padhi has this question. So that how often do you pursue it for cryptococcosis or adenovirus in acute colitis?
You are breaking up a little bit. So how often do I see this? What's the question?
The question is, how often do you pursue it for cryptococcosis or adenovirus in acute colitis?
I would say I look for these organisms every time. I think they are very rare. There are very specific situations. We do have a very large transplant cohort of patients. So I would say for specific patients that may be at a higher risk, I search for these things. I pursue them a little more, I would say, particularly when I see features that may be concerning histologically, but I don't see the organisms or the viral inclusions on H&E. And that could be ordering additional stains at the time, depending on the clinical picture. Sometimes we talk to the clinicians. If they are concerned enough, we pursue other methods. And you know, they may also do additional clinical testing for these patients. So I think there's not really a hardcore rule on how to study these cases. It's case by case and kind of depends on the level of suspicion. I think to do it on every case, maybe because you see a neutrophil, is not worth it. You're going to have a lot of you know, negative results. I think in the cases that you are dealing with a patient that is a higher risk patient for a particular infection or multiple infections, particularly immunosuppressed cancer patients, transplant patients, and so forth, there's more value on pursuing those cases a little further. And many times, you know, it starts with us having a certain level of suspicion using histochemical or immunohistochemical stains, and then we refer some stuff to molecular testing or clinical testing as needed.
So another question is from Nan, who wants to know, please explain the differences between ischemic colitis and angiodysplasia.
Well, what I want to say is I will consider angiodysplasia or arteriovenous malformations within the spectrum of things that can cause ischemic colitis pattern of injury. As I mentioned earlier during the lecture, ischemic colitis will be a pattern, right? So multiple things can cause this, and the underlying cause of that pattern could be many things. Could be from something systemic, so hypotension, for example, a patient with shock may develop ischemic colitis, but could be something localized to the bowel, like an angiodysplasia, for example, that is causing ischemic changes in a particular segment. So that's the way that I approach this. I think we're gonna have probably, I don't wanna go too deep into this because I think there's gonna be a lecture down the road that we were entertaining and talking about ischemic colitis and the differential diagnosis. I think ischemic colitis, most of the cases that we see are fairly straightforward. There are no distinct features, but I think it's also an opportunity for us as pathologists for improvement, learning more about what to look for in these cases. Many times sampling is critical and looking for specific causes that lead to ischemia, not just additions, for example, or volvulus or cardiovascular disease. I show you a few cases of vasculitis. Angiodysplasia is the same. Many times they do know the history. Sampling of these cases can be challenging because sometimes when the specimen comes out, these are resections, they are fixed. The vascular lesions collapse and they are hard to find on the specimen. So sampling is kind of critical, but I will leave that for the future because there's much more to say about that.
Right. Amanda has this question for you. How to tell diverticulitis from IBD in a biopsy with no history?
Yeah, I think I kind of mentioned that a little bit before one of the previous questions. I think it's very hard. I don't think there's a reliable way to tell them apart in a single biopsy, that they're biopsying the area that is inflamed in diverticular disease, associated colitis from an IBD case. So it's a clinical pathological relation, as I said before. It requires knowing what the adjacent mucosa looks like, that the patient has diverticular disease, that there's no other clinical manifestations. So I think in those cases, I think it's fair to say chronic active or active colitis, whatever the pattern of injury is, and provide a differential diagnosis. I think the clinicians need to know that they need to do their part to come up with a final diagnosis.
So there is a question from Venkatesh. He wants to know, how do you differentiate cryptosporidium, isospora, and microsporidium?
Yeah, that's yeah. There are distinct features that you can see. Typically, microsporidium are these 4 to 6 micron microscopic dots that you see quite in the lumen. Isospora tends to be more in the. Honestly, I don't recall a case I've seen it in the colon. I think we see it more commonly in the gallbladder. Actually, there are several reports in the gallbladder. I don't recall a case in the colon. They are more like almost banana shape, intracytoplasmic. They may have a halo, so they're a little bigger. Cryptosporidium also intracellular many times, much smaller dots. So I think if you pull up pictures, I unfortunately that wasn't the topic specifically, so I didn't put any specific features, as we don't see those typically in the colon. Cryptosporidium probably is the one that we see the most in the colon, but histologically they may look different.
Right. Suma wanted to know that what are the pointers to differentiate reactive atypia due to adjuvant chemo or radiotherapy from recurrence?
From recurrence of what? You know,
Tumor, I guess, from recurrence of the carcinoma.
Reactive atypia from neoplastic.
Right, reactive atypia due to radiotherapy or chemotherapy.
I pointed out how cases of ischemia, for example, in the regenerative phase can look very worrisome. So I think the features that we look for are very specific of the organ, because I would say that if I'm thinking of pancreas, it's very different from regenerative changes or atypical changes in the pancreas in the setting of reactive versus dysplasia is very different from in the colon. But looking at the colon, the things that they look for is, first, in that case that I show you ischemia, I knew that the patient had ischemia in the background. Many times it's IBD in the background, and we have regenerative changes in that setting. So we know that the background has a certain level of injury or inflammation. that should make us pause before we call something frankly neoplastic in that setting. But purely histologically, I would say in cases of reactive, you're going to see increased NC ratios, sometimes some nuclear hyperchromasia, sometimes stratification, all those features, and even mitotic figures, things that we typically see also in neoplasia. What is helpful to tell them apart many times is, in cases of regenerative changes, you see a slow transition between the area that looks regenerative into the adjacent normal mucosa. So it slowly goes down to normal. While neoplastic changes many times have a sharp transition. So you can almost draw a line between the changes that are neoplastic and the non-neoplastic mucosa. I would say surface involvement. This is not an absolute, but if I see changes that are distinct, sharply demarcated, and they also involve the surface of the mucosa that we're dealing with, that is a feature of neoplasia more than reactive. But I would say you have to put all these things in context, right? I mean, it's kind of hard to use a single feature. I think it's a constellation of features. But I would say in the colon, for example, having these histologic changes that occur with a sharp transition to the adjacent mucosa and involving the surface should make us think of neoplasia. I will have to say that in the setting of IBD, which is not the topic for today, but just as a quick comment, there are instances in which we leave those cases as indeterminate for dysplasia, just because there's not enough convincing evidence that it's neoplastic. So that is a possibility for IBD, but we try not to use indefinite for dysplasia in other settings because it's less meaningful. We try to make a call, but there are cases in which it's challenging. That being said, in the case that I show you today of ischemia, I know the patient has ischemia, it's reparative. I will have a very high threshold to call that neoplastic. And many times what happens is every section looks the same. So it cannot be that every section is neoplastic, right? So it's another clue that maybe should make us pause and reconsider a regenerative change.
One more question. Nilesh has this question for you. How do you differentiate NSAID-induced injury from Crohn's disease when history is not available?
Yeah, good question, right? We always wonder. I would say, and this is true for anything that can be taken over the counter, including vitamins or different complexes that people may buy, teas, herbals, any kind of thing that can be bought over the counter. Patients many times do not recall or they do not consider the things medications or toxins in any way. So when they are being asked if they are taking anything, they are not in a prescription medication, so they will probably not acknowledge all these things that they are using. This is common in the liver when we are dealing with potentially DILI, that we don't really have a history that highlights anything specifically for us. And this is because the patients, they're being asked, but they may not have recollection of these things that they're taking over the counter. NSAIDs are a great mimicker of everything, pretty much every single pattern that we can see in the GI tract, including ischemia frequently. So there's really not a good way to differentiate on a specific case NSAIDs from other things. So I think it's very rare, unless the patient has, for example, rheumatoid arthritis, and they've been on NSAIDs, high-dose NSAIDs for a long time, to put that as a high etiology in the differential diagnosis is very. I would say it's very hard to do that. You have to have a very compelling history to support that diagnosis, because there are so many other things that can present similarly that many times we can't tell. So I would say there's really not a good way to differentiate NSAIDs from others on histologic grounds alone, just because it will be in the differential of many things that we see in the GI tract. So the key to that diagnosis is to have that history. So if you don't have the history, you can't really make that diagnosis with certainty.
Right. So another question that I see, Pavitra Pushpanathan wants to know, how do you differentiate prolonged infection from Crohn's disease, especially with only mild architectural distortion?
Yeah, these cases are challenging. I have to say, chronic infections like the ones that I show you, mycobacteria, amoebas, they are not very common in the US, although we see them. The same for parasites sometimes. They are not very common in this country. They do happen more frequently in other sites, in other countries around the world. So people are, they have a different level of awareness, I would say. But we definitely have seen cases that were labeled, you know, there's a case I recall that came here for a second opinion, and it was diagnosed as Crohn's disease. For some time, the patient was not getting better. Actually, was getting worse on immunosuppression. It turned out to be a case of mycobacteria. So I think the key to this is to have a high level of suspicion again. If you see, for example, in the differential of Crohn's disease versus tuberculosis or any mycobacteria, I would say if you see too many granulomas, and in particular if they are necrotizing, that's not very typical of Crohn's disease. In fact, if we think about Crohn's disease has granulomas, but up to 30% of cases will have granulomas. So commonly we don't see a lot of granulomas in Crohn's disease. So if you have too many, it's too good, I would say consider an infection. So it's having a certain level of suspicion that will lead us to order these stains. As a general rule, I have to say, if I'm making the first time diagnosis of any patient with granulomas, I do order the EFB and GMS stains up front in any case, independently if I see necrosis or not in the granulomas, because many times you don't. The truth is most of the stains come back negative. The stains they do have a low sensitivity. So if I'm concerned, because the patient is presenting in a particular way or has risk factors, I may highlight this to the clinician. We may pursue this on PCR. But I think histologically, there may be a significant overlap between these infections and IBD that sometimes may trick pathologists into diagnosing these cases as IBD when in fact were infections. But I pointed out, like sometimes there are clues, like for example, amoebas can be subtle. I've seen plenty of cases of ulcerative colitis in a more reparative phase when they have histiocytic infiltrates on the surface of the ulcer. I'm sure many of you have seen this. Paying attention to the chromatin. Are these truly histiocytes or degenerating cells that are dying in the lumen, or are these amoebas? And I would say I've seen cases that are challenging too, that I wasn't able to be certain that there wasn't any amoeba. So we just highlight those cases to the clinicians and they pursue additional testing. That's all there is, right? So I think it's okay to point those things towards further testing and kind of discuss these cases with the clinicians. In many cases, we can make a definitive diagnosis. But yeah, there is significant overlap. These cases can be difficult.
Right. I think that's all for today. So sorry that we will probably not be able to answer all the questions that you asked. And in fact, Dr. Allende has given her Twitter account, so you can reach out to Dr. Allende on Twitter. So she would be able to answer some of your questions, and maybe she can go back later and answer some of your questions on Facebook, which remained unanswered today. And thanks a lot. And Dr. Allende, thank you so much for your time. And you would be so happy to know that you had at least hundreds of viewers from so many different countries. And I could keep track from viewers from at least 33 different countries, including places like island of Kiribati, Greece, Ethiopia, Tanzania, Philippines, Nepal, Netherlands, to name a few. Thank you all for joining. And as always, please, if you like our lectures, please subscribe to our YouTube channel. That is Patcast, and we are also available on Facebook. That's also Patcast, so you can follow and like our page so that you will remain updated about the upcoming lectures. And the next lecture is actually another GI PAT. So that's coming up on May 12th at 8 a.m. Eastern Time. So that will be presented by Dr. Ford from University of Pennsylvania, and she would be presenting on a logical approach to luminal GI biopsy. So hope to see you all there. And there was a lot of requests from many of your viewers about GYN PAT lectures. So we are working on that, and please stay tuned. So till you know about it. And thank you again, Dr. Allende. Thanks a lot.
Thank you, everyone. It's mind-blowing to see everyone coming from different places. It was really fun to do this, and I hope I can answer the remaining questions via Twitter or other social media, so feel free to contact me. Have a good day, everyone.
Thank you again.